Hi, everyone. Welcome back to the podcast. I'm Dr. Lindsay Renzullo,
I'm Dr. Krista Vernaleken.
and we have a very special guest today. I mean, all of our guests are special, but this one in particular, we just adore. We have today Dr. Andrea Looney. She is an anesthesiologist, and she is here today really just to talk about anesthesia in the veterinary world and all of the wonderful things that come along with that. So, Dr. Looney, would you want to kind of give the audience a little bit of a background about, where you, went to school, got your training, and things like that?
Sure. Lindsay, Krista, Lauren, Rachel, thank you so much for having me. I feel special because you guys are so near and dear to me. So yes, I joined then IVG, now Ethos, back in 2012, 2013, and prior to that had been working at both Cornell and Tufts, and had gained my veterinary degree at Cornell and way back when, 1989. That's
Woo,
crazy.
woo.
Yeah, and since then had gone through a residency in both anesthesia and then rehab and pain management, sports medicine. And so I'm just delighted to be part of the crew at this great hospital. You guys, I just adore you just as much. So thank you.
Awesome.
Tell us, so we want to introduce our audience a little bit to the field of veterinary anesthesiology, which, I think that most people have a concept of what anesthesiology is in human medicine, but then the idea that its existence is also present in veterinary medicine, I think is sometimes new to people. So yeah, tell us about veterinary anesthesia,
Yeah, that's
just everything about it.
And go.
And go.
And you guys must know that I could chat instantaneously forever and ever. So, yeah, the field of veterinary anesthesiology came about as a kind of a branching of the surgery college back in the 80s. And at that point in time, it was actually joined up with critical care. And the idea was to provide everything that the surgeons could not provide, the care of the animal going into surgery and the care of the animal kind of firefighting through surgery, and then, of course, post-operative care. It split off from the critical care college, I think in the early 80s, mid to late 80s. And since then, really, it's been a hidden aspect of surgery. Most owners kind of assume that when anesthesia is provided by a doctor, a veterinarian, either in general or specialty practice, that the process is kind of streamlined and part of surgery. And actually, it's become so intricate around the drugs that are involved and the techniques and the training, the troubleshooting of the equipment, the monitors, the machines, that it became its own specialty. And we're really blessed, as you guys know, to have so many great technicians who not only are well trained in that field, but actually have a huge interest enough to specialize and to go on with that, and even specialize for each one of the specialties in anesthesia, like ophtho anesthesia or neuroanesthesia. So yes, it's been hidden for a while, but I appreciate this opportunity to bring it out and to address people's concerns about it.
Well, and we've had other specialists on the show so far. And I think that, it brings to light that veterinary medicine is getting more advanced and more specialized. And we do have different, specialties because as a general practitioner, or as an ER doctor, clients really expect us to sometimes know everything. And we have to be honest and say there are certain cases or certain times that we just don't know it, or this is beyond us, or you need to go to a specialist. And so the same holds true with anesthesia. Anesthetizing a patient is potentially very detrimental to their overall health. And if there's a lot of underlying conditions with that patient, anesthesia is not, like you said, cookie cutter or streamlined for these guys. These guys need somebody that's going to be able to, really custom tailor that particular protocol for that patient so that patient has good anesthetic depth, good pain control, and comes out of that procedure, a healthy animal. And so, I remember when we first launched, anesthesia at Bolger, at that time, I had been doing all of my own anesthesia for years. And, I said, oh, it's very interesting. This will be very interesting to have an anesthesiologist, but I think I will be fine
You
managing
don't
all
need
of
it.
these
You don't
anesthesia
need it.
cases. And the amount of knowledge and the amount of intricacies that the anesthesia team has brought to Boulder, and managing some of these really, really difficult cases has been absolutely amazing. Something that we're very, very lucky to have.
That's great. It's great to hear that too, that, it's so well accepted. And I've always felt that within your hospital and all of our Ethos hospitals, that we're really lucky to have a team approach. But yeah, it's one of those situations, right, where it's done so many times every day in your practice and in my practice that we kind of take it for granted. But really, it's about titrating poisons.
Right.
Essentially drugs and techniques that are capable of, rendering a person or an animal to a state of unconsciousness that has to be reversible, right? We have to get them back. And yet it has to be enough to allow stillness for the surgeon to do what they're doing. It has to provide hopefully a loss of memory for that patient so that we can go ahead and have that patient not wake up terrified. Has to allow for good pain relief, and then, just as you said, it all has to return that patient to a very healthy state at the end. So that reversibility factor means that it's a fine line. And I remember back early in my residency, one of my mentors showing me this diagram of cardiopulmonary and neurodepression, then in a bunch of lab beagles, that actually the fine line between true shock and irreversible death and a plane of that level of unconsciousness was so fine.
Mm.
And that's what we need to be. And thankfully we have so many great again, minds together on this, because it wouldn't matter, right? With all the equipment we have, the great equipment and all the monitors, if we didn't know how to interpret that and how
Right.
to use them correctly. So
Yeah,
yeah,
that's something veterinary anesthesiologists in the world are rare compared to the number of anesthesia procedures that happen every single day, right? Like
right,
the
right,
majority of the time when you bring your pet to a smaller general practice, there isn't a veterinary anesthesiologist there. And, that doesn't mean that they can't do a great job. It just means that there's going to be a limit to what they can do and know. And I just can't, when you go into a surgery, like I remember doing the C-section recently that I was just like, all right, so I'm doing the C-section. I've got to monitor the patient. Not I'm monitoring. I mean, I've got a technician monitoring the patient. I've got to anesthetize this patient. And it's like got 9 puppies. And every one puppy comes out and they're like, do that. What this is happening with this puppy. And this is happening. I'm like, guys, I need an anesthesiologist here because I can't do 9 puppies and the mom and the surgery. Like, so a lot of the
right,
time you
right,
just run into these situations where you're just like one person cannot do all of this. And
Right.
we need this extra, we need extra help and hands and somebody who knows the drugs and to deal with that part of it so that I can do the surgery.
right,
It
right.
just, and having anesthesiology around is like that, even for routine surgeries, you run into complications that you're like, well, this will be, it'd be okay. I'll give it fluids or whatever. Its blood pressure's low. But then someone comes in and is like, well, but I could give it this. And then they do.
Right.
And then the blood pressure is excellent. And we know that that has a long-term impact on how that patient recovers and how it does. Maybe in 10 years, it's not going to develop kidney failure that it would have because of that anesthetic incident. We just
Right.
don't know a lot of that. So it's
Yeah,
amazing how much. Yeah.
that's the key right there, right? I mean, you're so right, because it's been done every day and it's done every day in practice. And we usually say that the success of that procedure is not about that patient just waking up from anesthesia, because 99 out of 100, thankfully, will wake up from anesthesia. It's about the health within the week to month to years later that we really want to prolong for that patient. So, in practice, I think in general practice, the level of those surgeries, thankfully, is a little bit less than in some of our practices, and so things tend to go well. But you're right. I mean, it's about bettering that patient for an improved outcome, not just waking up, but an
Right.
improved outcome hemodynamically. When we say that term, and it doesn't mean a lot to the average owner, but really what we're trying to do is prolong quality of life
Right.
long term for that patient. Yeah.
Now, one of the benefits of working at a referral hospital is, one, we have anesthesia as a service, but we will see some of these cases come in that actually the regular vets may say, I'm not comfortable performing this surgery. Anesthesia is too risky. Or we even have owners that come, and they've sort of made that proclamation saying that this anesthesia is too risky for this patient. In those cases, what are your, being a specialist, and being in anesthesia, what are your sort of ways that you work around, or ways that you sort of work up a case up like that?
Yeah, that fear of anesthesia, I always say, is healthy in a certain way, but we want to make sure that we guide the owner and the referring veterinarian through that process scientifically, right?
Yep.
So the approach to that really is looking at what we call anesthetic risk of that patient. There's been huge studies done in veterinary medicine, thankfully, that have looked at what we call factors going into surgery and anesthesia that affect the outcome. And one of the largest things that affects the outcome is that health of the patient going in. So, when owners or vet referring doctors come with a fear of that anesthesia or referral of a case for anesthesia, really it's about fine tuning what that health of the status of the patient is going into surgery. And what we mean by that is, there's certain critical body systems going into anesthesia: the heart, the kidneys, probably primarily, the lungs, and the brain, central nervous system. And if we look at all those and really try to evaluate them through an excellent physical exam, through some diagnostics, I have to say blood work doesn't matter as much to us anesthetically as function of those organs does. And then imaging is a huge help for us now, whether it's radiology or ultrasound to look at actual cardiac output in terms of function of that muscle, the myocardium, perfusion of the kidneys. So those are the things that we're thinking about as a criticalist or an anesthesiologist going into that surgery. And I really appreciate owners and doctors, referring doctors, concern about that. I do think that's probably a
Yeah, I
healthy.
always like, I feel like it's one of those things that, like, anesthesia is this double-edged sword where we should be really concerned about it, and we should have a health fear. Maybe fear is the right word, maybe, but it shouldn't mean that we neglect important procedures because we're scared of it, because those things have an impact on health too. I hear so many times, a pet with its teeth rotting out of its
Right.
mouth, where the owner's like, well, but he's 15 and he's too old for anesthesia. Those are always the kind of things I'm like, but he could be 20.
Right. Right.
Right? He
Exactly.
could have
And
5 more years. So that's always, do you hear that often, Andy, about like reasons that maybe shouldn't be reasons, or we can work around these reasons for
absolutely.
anesthesia? Yeah.
Absolutely. And I welcome people coming in to really evaluate that. I totally agree with you, Krista, because I think so many animals suffer. And
Mm.
part of the anesthesia college, oath and ethics are to really avoid that pain and suffering in the long run. So we have so many great ways to get that patient through an anesthetic event. So many safe, healthy ways, thanks to the level of monitoring, the level of equipment that we have, the level of technique, and we really can get around that with that team approach. It's not just about one person. You're right. Lindsay, you said earlier, it's, you can always have someone coming in. Well, we wouldn't be able to do what we do if it weren't for you guys creating that hemostasis and the right tissue handling, which is essential parts of that. So yes, I totally agree. We need to address that fear and turn it into a healthy respect. One of the things I've always worried about, is, and I say this with due respect to you guys, in terms of general practitioners, because you do so much preventative work, but I wish owners would invest more in that risk assessment, because that's where you guys come in as such good clinicians in terms of diagnosing a heart murmur or listening to lungs in a different way, looking at the kidneys in a different way. And I'd much rather have them invest in that workup versus their quote unquote annual vaccines. And I'm sure it's a fine balance. So how I would turn that question back to you guys. How do you coach owners when funds are so limited nowadays to do that?
Yeah. I mean, we have a lot of those discussions. I think that it's almost the good thing is that a lot of those preventative things are relatively cost effective compared to some of the bigger diagnostic tests and everything. And I think, there are some families that are just not ever going to be able to swing, doing the $500 or $1,000 dentistry, and they just can't.
Yeah.
I think that a lot of the time with these procedures, when we say, this is my wording is oftentimes like, I want to actually deal with, these things right now while your pet is otherwise healthy, and do this as a preventative, as opposed to having to, remove a bunch of rotten teeth that have been painful for 2 years. And I also don't want, 15-year-old cat to also have dental disease, right? I want to have kept up with it ahead of time. It's going to be way more expensive and painful to deal with then. So, and I think with those workups pre-op, I think when you have an owner that is invested in doing the procedure, and then you say, Andy has a heart murmur, so we do need to look at that beforehand, because that's going to, do everything that we can to ensure that this anesthesia is as safe as possible. They're kind of all on board once they're on board with that. It's like, it's getting them to the point of doing the procedure, I think.
Yeah, I mean, it's a struggle for sure. And I think that, being really cognizant of everybody's personal situation, because sometimes they'll say, well, I only have, X amount of money.
Right.
And that money may not allow us to do all of the pre-op stuff that we would love to do before that anesthetic event. And that happens probably more frequently than we would like at times, right? So at times we would love to be able to have the, echocardiogram and all the lab work and an ultrasound before we actually do the anesthetic event. And sometimes we are challenged with the fact that they can't afford all of that beforehand. They can only afford maybe getting that procedure done. And so then it is really a fine-tuned balance of using our clinical judgment and our assessments on that patient. So saying, this is a small, tiny dog that's got a heart murmur. It likely has this type of cardiac, issues going on because of the heart murmur. I'm going to use the best cardiac friendly protocol that I know how that would sort of fit this particular patient of what I think is going on. So it actually uses a lot more, foresight, as the veterinarian, of figuring out what may or may not be going on without necessarily that official diagnosis. And I think that is something that humans, human doctors don't necessarily have to deal with I guess it might be this all the time, because they can often get those tests, right? Where we're, really using all of our knowledge base and really figuring out for that breed of dog, for that type of cat, what could be going on. And trying to get the best possible anesthetic protocol, because holy cow, there are so many different ways of anesthetizing a patient. That's the other thing. People think it's just this one med and this one protocol. And in reality, there's so many different cocktails of drugs that you can use to sort of help that patient get that anesthetic depth. And that it really takes the skill of that doctor to figure out how to do this in a safe manner.
Right, right. I mean, I love what you guys have both said, though, because it really, I think it highlights the paucity of information that we generally work with compared to human anesthesiologists, and the variability in not only the different breeds and species, but in the individuals changing lifetime, that, it's not about changing drugs all the time, but, basically knowing how to modify a set of drugs appropriately that we become so familiar with that we have at least good faith in what we do and how we use them, and a predictability that I think really depends on so much, and also really highlights how no matter what type of economics we're working with going into the procedure, it really comes down to a really good clinician and a good physical exam, because so much can be done, as you said, with just knowing that, hey, this is an older dog, and based on my experience and based on what I'm visualizing, hearing, feeling in this patient right now, this is what I would use. Here's the minor modifications in these doses, and go.
Yeah.
So yeah, I think that's really, it's the quality of that, and then having that team to help with all of the nuances that might happen in anesthesia. Having, it's about training that team. I think for the modern day, the veterinary anesthesiologist is about identifying what works best for each team. You guys are basically a doctor and a few technicians and assistants that work so well together, and we have to figure out what your familiarity, what your comfort level is, and just make sure some boxes are always checked for the hospital as a whole.
Now, the anesthesia event we always talk about, because I feel like that's sort of, it's in the title, anesthesiology, the actual surgery. But then, there's that whole part afterwards of sort of recovering and pain management, and how we sort of, manage those patients afterwards too as well. So how, after post-op, how does an owner necessarily evaluate if their pet is in pain? How do we evaluate the pet in pain? What are some things that you do to sort of help manage that after the procedure?
Yeah, that's a really great question. I think we're lucky that we have so many valuable pharmaceuticals, especially within our larger hospital system, the Ethos hospital system, and certainly, regular GPs have that too. But I think we're blessed to have a variety of those for each individual. And thanks to the evolution of, the pain management assessment, recognition, treatment, associations and ethics of about 15 years ago, I'd say now we make sure that we're ahead of that pain, and irregardless of whether the patient is gonna maybe feel something or not, we are treating for it, period. And if that patient tends to have what we call breakthrough pain, we're even treating for that. So we do that by a system of what we call scoring, which is to take some standardized means of looking at a patient postoperatively compared to preoperatively, and their vital parameters like their heart rate and their respiratory rate. And then there's some behavioral characteristics that we associate with pain, and doing that on a very regular basis. But the gold standard to figuring out if an animal is in pain in the hospital is actually treating it and seeing if the patient responds appropriately. Because pain can mimic many different things. Fear, it can mimic stress, it can mimic excitement from those drugs. So figuring that out, I think, is more on us in the immediate postoperative period. And then going home, how does an owner do that, right? I think it's hardest for us, and having served, as an owner myself, and trying to figure out if my patients, my animals are in pain, it's really tough, because you want to make sure they're comfortable. There are children, and that makes it very difficult. Sometimes we over scrutinize, sometimes we over treat, but I would say just sticking to the basics of what we call quality of life parameters at home. Is their mobility? Is their interaction with the family as normal? How is the appetite? Is the animal focusing on a certain surgical area or on an area that's close to that? And in their general routines, are they acting like they did pre-surgically? Those are the things I think an owner should be thinking about. And it is tough. It's really tough. Because we're over concerned, and we as owners, we really want to make sure. And I assure all the owners who would listen to this that we too, as your doctors, are over concerned. We really try to focus on that. And I think Bulger I've always admired in terms of its ability to balance those things, because you guys as GPs and specialists together have such a great team approach that I wish we had in all of our hospitals to have that. But hey, our general practitioners thrive out there and work with us well, so that's great too.
You know, what's funny? I feel like, and this is not any sort of negative comment. It's meant to human medicine, but I feel like veterinary medicine in general seems to really be so aware of those pain parameters and control. I mean, we have, dogs come in hit by a car, they get an injection of a pain medication. I would say within the first 2 minutes, cats that come in and have urinary signs, we're giving them a pain medication right away. I broke 3 vertebrae and I didn't receive pain medication until after they took x-rays and realized that I broke my back. And it happens all of the time, right? Where you get humans that are just, rolling in pain and they don't give medications to these poor people in the ER, where I think we're almost hyper aware of these animals and making sure that we're giving them appropriate pain control, when they're coming in. So it makes me proud of us as a profession that we're at that level. It's sad if you get hurt to go to the ER. Take a Motrin or something before you go.
Take a Motrin in preparation, because you're certainly not going to get it in the ER. Yeah, that's so true though, right? And I think the opioid crisis has made it even harder for human medicine to appropriately address that, which you would hope and pray that anti-inflammatories would come up in that process, but I don't know why. I mean, I had a friend who was in the ER 2 weeks ago, and she said the same thing. She's like, I don't know why they never even mentioned taking ibuprofen or naproxen or anything. And she called the doctor, and he's like, "Oh yeah, sure. We forgot about it." Well, I really think you're right. We really do a great job. Maybe we need to focus a little bit more on the anti-inflammatory aspect in our patients. I hear all the time, and I'm sure I'd love your guys' take on this, that you know and an animal come in the other day with a bone tumor, and the owner was told that just, out of fear of causing renal failure in the patient, she was told to keep the animal off non-steroidals. And my heart just broke completely looking at this poor dog, because if we had a break in our back, like you said, Lindsay, or a bone cancer, we would want pain relief in the form of an anti-inflammatory as well as an opioid. So do you guys see that often, or tell me your take on that?
That's actually sometimes a bit of a conflict between general practitioners and like critical care and some specialties that are really focused on, the critical moment. A lot of these patients that come in shock or something, it wouldn't even occur to an ER doctor to give them an NSAID, because that could do them harm in that moment. But I think the pendulum then swings the other way, that like you have to, I have so many animals that I see on a regular basis that are these like really creaky little old dogs, and the owners for whatever reason haven't been able to do blood work, and so no one, everyone's just like refused to give them anything. And I'm kind of like, but they're gonna, you're gonna be forced to make a decision to euthanize that pet that much earlier. Like, let's try, like, darn the blood work, forget about that. Like, let's just try something, and it does tend to be that thing where you don't want to, as a vet, do harm. But sometimes by not doing something, you're doing harm. And it's an important thing to play around with. And yeah, I'm all for like, let's try something. Let's just try something.
I like that, by not doing anything that you can do harm to. And I think that is a huge point. And I think as long as owners are aware of, the risks and the reason why we want to do things, this sort of goes back to, talking about if they can't do all of the preoperative, workup that we want to do beforehand, before a particular procedure, but knowing that if they don't get that procedure done, like their quality of life will be impacted significantly. And the same thing with, even just simple blood work, there are things that we can do as long as the owners know why we're asking them to do certain things. And if we can't, then okay, but we need to help these patients out. But yeah, the pain control in veterinary medicine, I think and I think it's evolving too, right, Dr. Looney? I think that, between the traditional medications that we would give, sort of oral medications, things that people can give at home. But I feel like all of the more non-traditional types of medications, like laser therapy and acupuncture. I mean, there's lots of other ones, right? That you have seen utilized in practice that seem to be beneficial to these patients.
Right, right. I mean, I applaud you guys for keeping the big picture and to, ask you to keep pushing as you always have done for the use of rational therapies in the patients, regardless of the diagnostics that are done. Because I do agree, the quality of life is a fine line between doing something and not doing something. But we can focus so much on a blood value for creatinine and making it perfect. In the meantime, the animal is, nearly dead.
Mm-hmm.
So I think that's great. Yeah. And I do believe the most of our techniques nowadays have changed a lot in that we now have modalities that we can use for pain relief, such as cryotherapy, such as the laser therapy known as, photobiomodulation, such as certain muscle stretching techniques that are, well used by some of our physical therapists and rehab technologists that are within the practice. So there's so many different techniques. We tend to use, a lot of very odd drugs that are used in human patients for chronic pain, rarely in our patients. I'd love to see that used more. Drugs such as Lyrica or pregabalin, some of the calcium channel blockers, certainly drugs that have a lidocaine-like feel to them, such as mixilotine, sodium channel blockers. I mean, these are just amazing opportunities for us and our patients to go ahead and to relieve that pain in a different way.
Over all of your years, I know this is going to be a tough question on the spot, but do you have sort of a favorite anesthetic case, like a case that was either really super challenging or something that, came that, you didn't think would make it and did really well? Or is there a case or cases that sort of bring up, or just a general type of thing that you can think of,
Oh, yeah.
that you
Boy,
have?
that's a good one, Lindsay. I'm sure you guys have ones that raised your hair on the back of your neck, Yeah, some of my favorite ones were actually within the Cornell employment time that I had, and anesthetizing large animals is just an unbelievable feat. And if you think it's a
Yeah.
balancing act for small animals, it's anesthetizing horses and cattle is just an amazing thing to witness. And I was really blessed to work on living in New York and working in Ithaca, a lot of racehorses. And I just have great memories of working with so many of them. It's challenging from the standpoint of just laying these animals down changes their hemodynamics and their pulmonary dynamics so much that is, the reason they stand a lot is they really can't live laying down. And so when we do surgery on them, we have to lay them down. We have to do it gently and get them back up. And they are their own worst enemies. So I'd have to say it's probably a couple of horses that really, they unfortunately had some orthopedic and some colic issues that just lengthy surgeries. And I remember standing in a surgery suite, with about 4 or 5 other surgery clinicians, with the colon and the intestines of a horse just draped around the room, trying to figure out how to untwist it.
Oh my
And,
gosh.
we were all involved in that, and putting that patient back in the stall and having it recover appropriately and stand back up was just an amazing feeling.
That just you're flashing me back to at
Right?
school, where I just remember going into these things, as a small animal major, you do your minimum number of large animal things. And I had never experienced really much with horses and cattle. And I just remember walking into surgery suite going, what are we doing?
Right?
Like a horse on its back,
Right.
its
And
legs
remember,
are up here, and you've got the
and
gowns that have to be like waterproofed up to your elbow, up to your shoulder, because
Yeah.
you have to get your arms. Oh my goodness. Yeah.
yeah.
Even
And then
some of
they
the
wake up
cow
in a padded
procedures, remember the cow
stall.
procedures, some of those surgeries you're doing where they're actually standing, you've just blocked that whole area. And so
Yeah.
you are arms deep in a cow that's standing, and you're
Yeah.
just, it's remarkable. Those
What
large
are we
animals, it
doing?
is impressive.
Right. What are we doing? Yeah, and yet, you return that same cow, Lindsay, to a farmer who continues to get milk out of it for another 4 years, and you realize price of milk nowadays, like
Yeah.
that one cow made a huge difference to that farmer. So it was actually worth you, like you said, Chris, it was worth you waterproofing yourself and standing in, ruminants regurgitate all the time. So we were living in like this cud covered in it, but it was well worth it. And then there's been some unbelievable cases at both Mass Vet and at Bolger that I've had the pleasure working with these, all the talented people there that have been just great. C-sections have been amongst them, as you said, Chris. It's so wonderful to see birth and happiness come out of that, something terrible. So
Yeah.
yeah.
That's
Yeah,
awesome.
we always, it's a little, our anesthesiologist on staff at our hospital's name is Stephanie Fasakis, and she, you can always tell when someone else is having a bad day because she's bouncing around very happy because she gets to deal with something that's very like, critical. So if she's like bouncing and has a smile on her face, you're like, oh shoot, there's something very critical happening, but she's on it.
Yeah. Yeah, it's a good feeling to have that around. So it's nice to be part of that. But again, I wouldn't be able to do what I do and have that art of mixing drinks as well as I do for each one of our patients if it weren't for you guys. And every case that comes to the table is a challenge for us, and it's not that we want to create something different and special for each patient because we have our familiarity and our usefulness too, but it is nice to have the opportunity to have all the different equipment, such as invasive blood pressure monitoring and just the ability to flash a myocardium to see if there's something there, versus getting a full echo, which is really nice. So Ethos has made that really possible. And I think we also, I welcome, and I know Stephanie does too, welcome the opportunity to speak to our referring vets to help them with their troubles anesthetically to troubleshoot, because their successes are our successes.
Definitely.
Yeah, that's the greatest. I mean, just being able to even like Dr. Looney, you were the sole anesthesiologist for many of our hospitals for a long time, and that didn't necessarily mean that you could be there physically at every single anesthetic event, but just being able to send, a quick email and say, look, I've got this, like this patient, this is what's going on with it. Can you just give me some, ideal doses or, and that we can provide to our referring vet community and help them out with some of those trickier cases that they're capable of doing on their site. They just need a little nudge in the right direction, right?
Right. Support, right?
Right.
Yeah. Well, we want to thank you so much, Dr. Looney, for joining us today. And to our sponsor, Ethos Veterinary Health. You can follow Ethos Hospitals on social media and ethosvet.com.
And please rate and review us on your favorite podcast platform or on YouTube. So we'll say goodbye for today. Thank you, Dr. Looney, so much.
Thank you so much. We'll see you next time.
Thank you, Dr. Renzullo and Vernaleken. And Lauren and Rachel, thank you so much for hosting us in Ethos. It's been a pleasure to work with you guys as always.
All right. Bye, guys.